Okay. I'm still learning how to do this. Okay, so welcome to the NorCal EMS Medical Advisory Committee, our run review for January 12th, 2016. Happy New Year to everybody. I'm your cruise director for the event. There are two cases. Both I think are pretty interesting because one of them has some interesting EKGs. The other is actually an interesting case with an 8-year-old with an altered level of consciousness. So, first case, we have chest pain, something that nobody ever sees, in a 78-year-old female. They respond code 3 to a private residence for a female having chest pain. They arrive to find this woman sitting on her porch with fire personnel in attendance. She's had multiple MIs. She stated that her last myocardial infarction, she probably said heart attack, but was 3 months ago. So the patient said she was sitting watching TV at 13:45 when she experienced a sudden onset of lightheadedness and chest pain. Pretty good description. Women tend to have other symptoms like lightheadedness, nausea, dizziness. States that she self-administered a baby aspirin. Hence the question on the test is, should you administer a baby aspirin even if they say they've taken their own one? And I think you should, because you never know what they may or may have taken. People take Tylenol and think it's aspirin, or Motrin and think it's aspirin. She took 3 of her nitroglycerin tablets, probably old and expired. And she had not experienced any relief from her chest pain.
You know, the question that I've started to ask when that happens is, if they've taken their nitro, is, did you get a nitro headache?
To see how potent it is?
To see if it's been sitting on the windowsill in the plastic container for 1.5 years.
Point taken. So,
You already did that page.
no, they repeated a lot of it.
Yeah.
So, the pain is sharp in the center of her chest substernally, radiates through her chest to the middle of her shoulder blades into her back, and the pain is 8 out of 10. So as an ED doc, I started thinking, does she have an aortic dissection? Nothing alleviates or worsens the pain. She denied recent illness, denied recent medication changes, denied recent trauma, headache, visual disturbances, denied dizziness, weakness, numbness, or tingling in the extremities. This was actually one giant paragraph. I understand really trying to get a good review of systems, but just listing 40,000 things, I don't know. No shortness of breath, no abdominal pain. She denied any vomiting or diarrhea, although she did say she was slightly nauseated and lightheaded. So,
But not dizzy.
but not dizzy. Upon assessment, her HE&T is clear. What that really means, I'm not sure. Trachea midline, JVD, nothing. Negative use of accessory muscles, equal chest rise and fall, adequate tidal volume, pretty good. I know everybody puts pelvis is stable. For a chest pain patient, I think you could modify your routine if you wanted. Negative incontinence, okay. I still don't know what, for the medics in the room here, what does posterior clear mean?
I would think backside is normal.
He just checked.
Within
the
I would
normal
assume the
limits.
back. HENT is head, eyes, ears, nose, throat.
Right.
Right, well that I know, but posterior.
Clear
Because
just,
it's
clear,
really-
clear just means there's nothing out of the ordinary.
It's because you don't
They're
like
talking about the
WNF.
back based off what I've seen before in documentation. You're right, it's not clear.
Thank you, Mr. Witherall. Mr. Lane here said that's because I don't like WNL, we never looked.
It's pretty much the same thing. I mean, it's true. We never look because people that put that generally don't.
CSM's intact in all extremities and negative for pedal edema.
That's good.
So, initial set of vital signs were taken by fire. Oxygen therapy administration initiated by fire prior to arrival. Continuation of oxygen therapy continued throughout patient contact. Good. Assessment in 12 lead. Good. She could stand and transfer. Good. Here's another little. This person has an idiosyncrasy. They say main stretcher. I'm not sure what a main stretcher is, other than the stretcher that you brought in with you. Sorry, I'm being persnickety this morning.
The secondary one is the one that they have underneath the bench seat in case the first one breaks.
Okay. Patient secured the main stretcher and placed into the life support vehicle without incident. I gotta tone down my snideness. It's too early in the new year for me to be this snide. So 12 lead transmitted to the hospital. Aspirin given, vitals, first nitro, IV access, transported code 3.
Ooh, wrong order.
Yeah.
That's not according to protocol.
Which line?
Yeah. 12 lead obtained again. Second one. Second set of vials administered of nitro. Base contact with questions or orders. Vials and 12 lead obtained. Third nitro administered. Vials and 12 lead obtained. So far, so good. Arrived at the ED and turned over. She's got allergies to Vicodin. Okay. Probably nausea and vomiting. Interesting that she's on metoprolol, a beta blocker, and amiodarone. So she must have some interesting rhythms. Mental status, good. Skin, cap, refill, good. Pain is non-reproducible. To the neck, back, and arms.
Is that your misspelling?
Which?
Pain? Last few words?
The radiating, yeah, that's my misspelling, sorry. Can't spell sometimes. Spell check didn't catch that. So, her vital signs.
You gotta hit it.
You gotta hit it, thank you. She's a little hypertensive. She's not tachycardic, which makes sense with her metoprolol. Her SpO2, talking about, is probably too high if she is having a STEMI.
Did it say how much O2 I know it was done by the fire department, which means it was a non-rebreather at 15 liters, because that's all they know how to do. And they continued it, but does it say anywhere yet? Okay.
No.
We have no idea what the...
Pain goes from an 8 to a 5. So, here's that question about, do you always believe what Mr. Computer says? Oh yeah, they do. 2 liters. Sorry.
Okay.
Aspirin unchanged, nitro improved. So here's the first 12 lead.
I know it's hard to read those sometimes.
Yeah, that's a tough one.
I wish it had the uninterrupted
Yeah.
line too, that made life easier.
So we've got some extra ectopic beats.
Yeah.
So if you look, this thing is saying inferior injury. And it really is hard to tell here. Yeah, you could make an argument with your rose-colored glasses that that's a P wave. And so if that's a P wave, then you can make the argument that that's about a millimeter ST segment elevation. And maybe a little hyperacute T wave starting here. This is something, I'm not sure what this is.
FLB.
Yeah, funny looking beat, you're right. again, you could maybe make a case for this as a P wave, and again, this is more ST segment elevation. Where I really start seeing that potential is in AVF. There's your P. This is clearly at least a millimeter elevation.
Yeah, look at the other one next to it.
Yeah,
Now you look at V3, so
it's right on.
it's just starting here. But if you look, so is this a big MI? Potentially. Let's take a look at the next 12 lead. There are 4 of them. So again, we have funkiness. And we have, again, it says ST segment elevation inferiorly. Yeah, the anterior lead doesn't look as elevated, but I see some reciprocal changes starting here in V1 and V2. So here's where it says it's a flutter. I'm not 100% convinced that this is a flutter. I think this is a shitty baseline in 1 and 2, because I don't see flutter in 3 AVF, 1, 2, 3, and so the medic went by what the machine said. So I think if you look at 3 in AVF, it's still consistent with concern for ST segment elevated MI. I don't think this is flutter. And again, the machine and the medic said flutter with competing junctional pacemaker. The machine's having a senior moment. I think that in this...
It does look like a junctional. It's more junctional than it is ventricular, though.
Yeah, it could.
That doesn't look like flutter.
No,
it doesn't look
there's
like
no flutter wave.
There's no
per
F
se.
wave. There's no flutter wave. The only thing you could call it might be is AFib, but that's not the case because it's regular.
But obviously she has conduction issues because she's on
amiodarone.
Yeah.
So
she's a mess.
She's a mess.
I mean, you can't take a flutter just by looking at 1 in AVF, but ignore the other 12 leads that aren't showing
flutter.
Or even, there's no flutter where you're not seeing an erratic baseline.
Right.
Because that's not a flutter.
I don't think it's a flutter.
I don't see flutter.
I see a lot of little crappy things going on there, but that's just a piece of it. The question I have is, were they hitting a bumpy road right when they did that? And
yeah, wandering baseline. Yeah.
I mean,
so
something else. Was she coughing or was she shivering at that moment?
Right, and there's no. They did not unfortunately send in a rhythm strip with it.
Of course, getting back to treating the patient,
she's symptomatic. She's getting nitro
and with relief.
And they transmitted the 12 leads, so there's a cardiologist who's going to figure out, and I can guarantee what they're going to do. They're going to say, we're going to put them on our own.
Right.
On the way to the cath lab.
So always be a little reluctant to believe what Mr. Algorithm says. So I think the care, well actually I don't really care what I think. What do you people think?
The care was, they did a good job. Was on.
I think the care was on.
They were, with a pain 8 out of 10, according to all of our protocols, there should have been a little bit of morphine going in there.
Yeah, we never got an update. It started at 8. They gave them 3 of nitro. Did we get?
It said
did it ever drop
improved,
it?
but it didn't give
It didn't give us a number.
a number. But
If it went from an 8 to 4.
5.
Oh, did it? Okay.
that's still high.
That's still pretty high.
And her blood pressure would tolerate a little happy juice.
A little bit for the patient, a little bit for the medic.
Oh, that's happened before.
They got a lot of vital signs too.
That was really good. I like that they got vital signs after each nitro and they documented it. So I think the care was good. I think the documentation was good. This brings up the point that you always think about what the 12 lead algorithm is saying.
So when it says that, he can either he can agree with it or disagree with it or confirm with the hospital. It doesn't really make any difference. I mean, she's not changing, in all honesty. Like you said, hey, just she's
It's-
on all kinds of crap. We'll see at the hospital.
The only concern I ever have with that is that somebody gets used to reading what's on the strip and quits looking at the actual patient and the real strip. And one of the things we do in our medic program is when we're throwing out a bunch of these things, I take a marker and mark out that piece of thing because I don't want them reading what the computer says. I want them to be able to read the strip. Because
See, when ours prints off, I like tearing it off, looking at that as this is still printing. This is what I see. Okay, the machine sees that. Okay.
the machine
I'm
agrees
with
with
the
me.
machine.
It's smart today.
Exactly. Machine's smart today.
I mean, because
Well, and usually your partner too. You'll say, hey,
well, not when you have an EMT partner. Sorry,
oh, that's what I'm
We're-
sorry. Yeah, you're right.
different system.
Okay.
But Bill, you have to realize that
I
when
don't quite have an EMT.
when Dan and I do the capstone exams at AST, he's always the EMT partner. So just remember that. Okay, so here's an interesting case. Altered level of consciousness in an 8-year-old. Dispatch code 3 to a private residence for a patient experiencing possible signs and symptoms consistent with an unspecified illness. That just drives me nuts.
I know.
Sorry.
That's a good dispatch.
Yeah. So they find an 8-year-old lying supine in a bed, although it's at a business, with both patient's parents and fire personnel in attendance. Unfortunately, the parents are Spanish speaking only, so somebody fortunately could act as a translator. Essentially, no specific medical history, not prescribed any meds, and no known drug allergies. In this case, actually, I'm going to try to follow up and find out what happened. The state of the patient was acting fine all day. She just consumed a normal dinner for an 8-year-old, pizza and soda. After dinner, she began to complain of a headache and suddenly vomited several times. I like this. No abnormalities observed regarding the vomit. It's just food particulate. They stated that the patient became minimally responsive and that she became progressively worse during the transport team's response. Never happened before. Trauma, illness, changes, meds, nothing. So what are you guys thinking right now?
Oh shit.
Something's really going south on you.
Yeah.
Progressively becoming worse during.
How about a tumor
Could be a tumor.
right on her brain stem?
Or did they give her anything else on the pizza?
New onset seizure, atypical seizure. Worst case scenario, what I'm thinking with headache and vomiting is the kid's got to bleed. Unusual in her age group, but not out of the ordinary. So no access to alcohol or drugs, illicit or prescribed. That was actually good. No, they usually don't say illicit or prescribed.
That next statement is very good.
Yes.
Markedly obtunded. Wow.
No, that states that no one else in the family is anything like this. So
Right.
it's not foodborne on the pizza if everybody ate the pizza.
Well, also there's no family history of, say, Sturge-Weber, which is like congenital AVMs, arterial venous malformations. Oh yeah, Aunt Betsy at 9 had this happen to her.
As if trying to get that from a translator to a Spanish family would be kind of interesting anyways.
Yes, indeedy. But yeah, markedly obtunded, minimally responsive to painful stimuli. I'd be going, oh shit, oh shit, oh shit.
Well, I do know, having worked at Barrio, I've had them pick mushrooms that they thought were good and put it in food and soups and things like that. I've had them have herbal things that if a child was sick or something, to give them these herbal products that there's
who knows what the hell they are.
Yeah, that didn't work out real well either. So there are cultural things sometimes that I would probably, hey, check and, you know, find out, you know, what else we got going here.
Excellent point.
This
though.
is obviously a treat with the gasoline here. There's something really going
Piece of
south.
treatment.
Yeah.
Yeah. So, responsive to painful stimuli, ventilating, oxygenating, which is good. Airways patent, GCS of 8, pupils are reactive. Although I really like this, left upward gaze deviation.
Told you.
Mm,
That's making me.
yeah.
I'm wetting my pants, going, "Oh crap!"
Yeah.
Yeah. As soon as I see the kid's eyes deviate,
Start tracking.
let's go. Let's just go. Quick.
And hopefully there's some place that can shoot her head.
Right.
Yeah. If you're really leaning that way. That's,
Moved to stretcher, transferred, put her on 3 liters. They started an IV in the left. Great. Again, blood glucose is good. I'm not sure why they attempted a second IV, but okay. They made contact to the cell phone. The ED doc, to their credit, didn't say try to intubate this kid with a GCS of 8. The kid was oxygenating well.
Ventilating well.
I wouldn't have done positive pressure ventilations either. I really like the fact that he verifies the appropriateness of not initiating positive pressure. That is good documentation, good thought processes.
And if they're monitoring cap refill, they know they're going to have a fairly, I know cap refill has a delay, but they're going to be able to make sure that the adequate chest rise and the adequate volume that they're seeing is actually corresponding to correct oxygenation to match their ventilation.
Right. So, interesting, they have some brief periods of lucidity.
yeah.
Meds none, allergies none.
Okay, can you go back 2 slides? What is the EDRDC?
It should be RN. I
Oh, okay.
mistyped.
Okay.
Sorry. I'm not the greatest typist.
Imagine ever waiting for them to arrive.
Oh yeah. Mental status. Again, now the drop down, this is where I got disappointed. Normal for patient oriented. It's like, oh, come on, guys. It's a chronic issue, though. Interesting vital signs.
But they're
How come
giving
it
her
says
GCS 6.
How come they're giving 6 when it said 8?
Right. Sats are good.
6 is almost dead. I mean, but
Mm-hmm.
okay.
6 is not good, that's for sure.
So, I think documentation was good overall, except when it came to the standardized drop-down menus. I think the quality of care was good. I think that they had a really critically ill kid, and I'm going to work on contacting that facility and finding out exactly what happened to this kid, because I'm curious now.
I think their care was appropriate because it was diesel or gas.
Yeah. You got going.
That would, when they said code 3 transport to the hospital, I had no problems with that.
Oh, yeah.
Because I do have a lot of problems with code 3 transports for.
Well, that's the other thing that happens too when they lose all connectivity to the child and the mom if nobody speaks Spanish in the back, right? Because you usually leave your interpreter there unless it's a family member or something. That now, you know, you can't get a complete history, or you know, you can't
If it was
continue.
if it was fire personnel doing the translating, they'd be in the back
Yeah,
of the ambulance
absolutely.
with me.
Yo, you, here, now. And here's the kid's 12 lead.
No,
Not 12 lead, 3 lead. I don't see anything.
it is sinus arrhythmia, which I can't produce on my
Your trainer?
rhythm generator.
Ew.
Really?
No, it doesn't have.
I don't, you know,
Because you have to call it, it's sinus. Every P, PQRS complex, it'd be exactly the same. It is irregular, but you wouldn't have that with an AFib.
Right.
It's just too perfect. It's just a kid that's heart is so good that it just doesn't always beat when it's waiting for
Yeah.
a signal that says I need another little bit of oxygen type stuff.
So, okay, there is no case 3. So that's the end of. I will
That was
try
a
to.
good one, that 8-year-old.
The 8-year-old's a
Yeah,
great case.
yeah.
I will try to find that out.
Well, because just to get to the right facility to help that kid, you know, we just call them EDAPs, but can you guys take care of him, because you might have to bypass a hospital to get to one that can take care of him. You know, because they're going, hey, our machine isn't working, or
So to get a kid who GCS down to 6 or 8, it's got to affect both hemispheres. So, as you were talking about toxin from funny little mushrooms, or a bleed causing increased intracranial pressure, the left eye deviation, that would really.
and that starts to usually pronounce itself more and more as it starts to deviate. Because I would wait for her to throw up, probably. Right, wouldn't you?
Yeah.
If it's a bleed in there somehow, is this thing, because obviously I think it looks like it's progressing pretty
It's
rapidly.
a central nervous system something.
Well, it's got to be global. It's not a fixed focal deficit. And if she had a seizure that it's not typical. Her presentation is not typical for an absence seizure, and it's not a fixed. It's not a focal seizure. It's not a generalized tonic-clonic. I mean, there's lots of subtypes.
But because the first, it said around that she was obtunded,
Right.
which is control delete, basically. So,
That's an interesting. I've never thought of it in those terms, but yes, that's control alt delete.
that's a major thing, although because usually if people have gone through that, go incontinent, usually, from my experience. There's something, when it's that bad, particularly little kids, they're usually incontinent. Wouldn't you agree?
And adults too.
Yeah, oh yeah, but particularly for little kids, is something's really bad has happened here.
Okay.
Now, was this up here or down Santa Clara?
It is
Up here.
I can tell you where, but I should write confidentiality.
Huh.
So yeah, that was a damn good case, and so I'm going to try to figure out exactly what happened. So for next time, it sounds like nobody wants me to go through any more of the subsections of the American heart, so I'll look for other literature to review. We'll do pain, adult and peds. Thanks to Tony's poking me. Thank you very much, Tony.
And the drug formulary to correct that.
I'll check the drug formulary.
And the and the requirements for mandatory drug allotments. Because if you're changing the fentanyl, you might as well change it all the way we've discussed in the past.
Okay. The other thing I may look at is TOR, the termination of resuscitation, because I think we're behind the times, and I think that there are probably more patients that we cannot necessarily have to resuscitate.
Cool,
Or,
thank you.
Thank you.
So I'll work on
That's a good one.
everybody sending me their comments for the hostile event / active shooter, pain, and then if I'll start looking through for the termination of resuscitation. I'm not where I need to be. I don't think the evidence is where we need to be for pediatric TOR, because that's emotionally charged. But adult, the guidelines have really advanced, and so. So any questions in TV land before we sign off? I don't think there's anybody left.
Oh, they're clear.
I'm here.
Yeah.
Thank you.
Yeah, good man.
Yeah, I'm here. I don't have any questions.
Okay, thank you everybody. Was this worth your time, I hope?
Yes, it was.
Okay.
Works for me. Yeah, it was a good day.
I need the C's.
Okay, have a good day, everybody.
Thank you.